So once we saw the MRI and saw that there was a cyst in the bone that was aggressive appearing, there was a differential diagnosis of 4 or 5 different problems based on Asher's age, and based on those it necessitated a biopsy. So what we needed to do was get a sample of the tissue in order to figure out exactly what was going on, and we were able to do that with our interventional radiologist, who took a core of the lesion, and the pathologists were able to look at that lesion and diagnose it as an osteosarcoma. Following that diagnosis, we needed to do a few more scans, including a chest CT, as an osteosarcoma, if this is going to spread, the most likely place for it to spread is to the chest. And Asher didn't have any disease in his chest, but we did find that this was a high-grade osteosarcoma of the femur, and it was only in the femur. We also got a bone scan to make sure it wasn't in any other bone. So at that point, our options for an osteosarcoma or a bone cancer, as far as the treatment go, is relatively a standard treatment. So what we start by doing is a very difficult course of chemotherapy. The reason we do that chemotherapy is we found over the years that patients who we just remove the cancer from the one area don't end up doing as well as patients who we treat with chemotherapy, because we assume there are small little micro pieces of cancer floating throughout the body, even though there's no evidence that Asher had any cancer elsewhere in his body. We had to assume that. So we give chemotherapy with the goal of both shrinking the tumor and killing the tumor, followed by a surgical resection. The reason we don't do the surgical resection first is because we like to see what happens to the tumor based on the chemotherapy, and see if we need to change the chemotherapy, or if the chemotherapy is doing the job to the tumor that we know exists, because then we can assume that it's doing the same thing to the other microcells that might be floating around in the body. Then we do chemotherapy after the surgery. And with this chemotherapy protocol, we're able to treat patients very well, and many more patients do well than don't do well based on getting chemotherapy, followed by surgery, and then chemotherapy again. So Asher did very well with his surgical resection. He had a couple of complications, one of which was an infection, which we had to put him on antibiotics. But then we were able to completely reconstruct his leg without doing any sort of amputation. And now we're almost a year out from the end of his last chemotherapy. He's doing extremely well. He's back training many people. He's squatting much more weight than I'd like him to be squatting, especially based on a very big reconstruction. And essentially back to his normal life. He's back to his normal size, and I'm very pleased with how he's doing right now.